with no time to lose and talk about real quickly where we've been and where we're going. I'm very hopeful that for many of you, a few of these slides you will have seen them, know them, see them in your dreams, and when we can do this one quite fast. So for the past several years, MassHealth has operated both a flexible service program and a community support program specialized CSP under our 1115 demonstration waiver that comes from the Centers for Medicare and Medicaid Services. As of January 1, 2025, these two programs are going to combine into a new health-related social needs framework. One of the biggest takeaways of this slide and the next slide is that specialized CSP is not changing. It is still a service that you know it today. We are expanding in certain instances the eligibility and folks that are eligible for this service, but otherwise it is and will continue to be the service you know. Flexible services, however, is ending. As of December 31st, 2024, this program will sunset, and this is actually a very exciting thing because it will move over into becoming a covered service for the ACO population, subject to some funding limitations, which we will talk about. I'm going to jump us to slide 8 to kind of show this graphically and see what we are looking at. So on the left-hand side, we see where we are today, pre-2025. You have flexible services in green and the specialized CSP in blue, and Flex is nutrition and housing, and specialized CSP has 3 services. It has 1 TPP, 2 CHI, and 3 JI. What's going to happen in January 2025 is those services will move over to the right-hand side, and we will now have a reframe. We'll have HRSN Nutrition, HRSN Housing, and HRSN JI, and we're really focusing on nutrition and housing in this webinar today, and we will go more in detail on these services, which are showing the high-level categories there, which have sub-services underneath them. You can go to the next slide, please. A few additional pieces about these services. So with the exception of specialized CSP, who is eligible for these services, point 1, you have to be an ACO member, again, with the exception of specialized CSP. All else, you need to be an ACO member. And then there are 2 types of these HRSN services across housing and nutrition. 1 is a required service, and 2 is a supplemental service. A required services are all our specialized CSP services. Those services must be provided. The member is eligible for them and wants to receive them. They need to get them. There's no funding limitations. For our HRSN supplemental services, the ACO will get to choose which service they want to provide. They need to provide 1 HRSN housing service and 1 HRSN nutrition service. And those services are once given or once chosen by the ACO must be given to an enrollee that is eligible, subject to funding limitations. So while a covered service, we do still have a budget limit in which the services get to a point where they cannot be spent on anymore. One other piece on our supplemental services, that if you are offering a supplemental nutrition service in particular that requires transportation to actually access the service, then you also need to provide that service. So a lot of details here, but actually all down in this one slide. Let me go on to the next slide, please. We're going to expand for a moment on baseline eligibility beyond just being an ACO member here, because this will help us as we begin to make our way into these service manuals that were released last week. So as we've seen in previous flexible service iterations, we have this chart that we have kept around for the past 4 or 5 years. It's definitely in my genes. And it has 3 columns, and you need to check a box. You, the enrollee, need to check a box in each one of these columns to be eligible for a service. That was true in flexible services. It will still be true in HRSN supplemental services, but this will be a baseline. And some of our services will require additional eligibility requirements. And so we'll walk through these quickly. Most of it is not changed. You'll have seen this before, hopefully. So 1, you need to be an ACO member. 2, you need to meet a health needs-based criteria. So here we've actually added a 6th health needs-based criteria. It used to be 5. It could be a behavioral health need. It could be a chronic complex physical health condition. It could be a need for help with an activity of daily living, instrumental activity of daily living. You could have repeated ED use or inpatient use. Pregnant individual with a high risk criteria or condition, and now a pregnant individual without a high risk condition. So 1 additional add that we're excited to be offering. And then also you need to check a box in this risk factor. There could be 3 risk factors. You could hit more than 1. You need to hit 1. You could be experiencing homelessness, at risk of homelessness, experiencing food insecurity. These definitions have actually also been updated a bit to comply with CMS. And so encourage you to look at our definition section. We'll talk about it a little bit more in the manual to understand where things are being updated and changed. Okay, that was a lot, but again, 3 columns, check in each box. All right, so before we move on into our service manual, I just want to set the stage a bit more for these exciting transitions that are coming. Over the past several years, many years now, feels like many years with COVID, many of you have all been instrumental to helping us serve so many folks through specialized CSP and flexible services. And we are thrilled about this success and excited to move to this next chapter where we move into this covered service framework. And as we do this, it is really important to understand that flexible services will be going away. That program will sunset as of December 31st, 2024. And now, in its stead, we will look to a more sustainable path of a covered service subject to funding limitations. So on January 1, there will no longer be flexible services, there will be HRSN services. Overarchingly, this is consistent with MassHealth's deep commitment to addressing HRSN needs of its members. We are thrilled to be one of the first states in the nation to leverage federal authority to cover HRSN services and use this more sustainable path of a traditional Medicaid service. We're continually eager to work with all of you, health plans, HRSN providers, stakeholders, to lay the groundwork for the sustainable transition. This is going to continue to be a partnership, something that we're eager to work with you on as we move towards helping our members receive these services and lay the groundwork for other states to be able to do the same. And we can't thank you enough for the work you all have done to help us to get here and the work that you'll all continue to do as we move forward. But this is going to be a journey, one where we're very excited to take with you. And it means that there's going to be some substantial change. We've been talking all year about this, but just make sure that we are all on the same page that this transition, it needs to occur per CMS as of January 1, 2025. And there'll be some substantial changes to how HRSN services are provided and paid for from what is today flexible services and what will become HRSN services. We've been talking about this a lot in our webinars with HRA. At the end of this slide deck, there's an appendix that links to all these webinars. If you don't know what I'm talking about, I encourage you to go listen to them, just sign up for the webinars that are coming out, and this will help you kind of get up to speed a little bit about the changes to come. We believe that this will move us to success and sustainability, but it will also require time and resources for implementation. We expect that about 12 to 24 months of a transition period for us to get to steady state implementation. And during this time, we're looking to work with you all to be creative to get us there. So there may be differences in previous years to future years on how we get there, to set expectations for how we move towards this steady state of services. Overarchingly, this is expected. It's a large change. There's a lot for us to do. We really hope that you will hang in there. You'll come in for the ride with us. We are committed to supporting you all to get there, to help our members get there and get these services. And we're so excited that you're here. So with that, we're going to jump right into the service manuals and unpack this a little bit for you, hopefully make it a little bit easier to navigate. Again, we have a lot going on here today, so we may continue to move along and tell you overarchingly about a service, but all of the information you need is there, and we really want to make sure that we have time for questions today. So last week, we were able to release the HRSN Service Manual. It provides all of you, ACOs, MDHP, HRSN providers, ways of following how to provide HRSN services. As we move to sunset flexible services, what you will see in these manuals is what we've been talking about in standardization. More defined services, more clear rules on eligibility across the board. We want to get to that place where a service in Brockton is the same service as in Waltham. So with that, what I'm going to do is ask that we move to the webpage. We now have one standard place that we're working towards, which offers the manual, and we'll continue to build this out for you. So feel free to check back. And you will see that the manual is split up into 3 parts. We have the definition section, the nutrition section, and the housing section. And I'm going to speak to you about the nutrition and the definition section. But before we jump into the nutrition section, I very much encourage you to start with the definition section. Please go in and read it in full so you know when to reference back to it. If you see a word in the manuals in nutrition or housing that you think you know, but you're not quite sure, back to the definition section. I know this seems obvious, but there are many words that seem like I know what that means. I know what food insecurity means. I know what a household means, but they actually have very specific meanings, and we want to make sure that you all have that. So the definition section has 3 parts, one that covers all, both the nutrition and housing sections, and then one just for nutrition and one just for housing. So please read, reference often. With that, we're going to jump right into our nutrition manual. Okay, so section 1 of our nutrition manual just sets forth all of our services, and you will see that we have a category 1 level and a category 2 level. This is greatly set up for me, because if you are now thinking, what is a category 1 service? Where can you go to find that but the definition section? We won't jump back there right now, but I'll just explain it for you all. The category 1 services, as you start to read and we'll quickly see, is the actual food the members will receive. It's a food voucher, it's a home delivered meal. It's meant to provide that necessary food to improve and stabilize or prevent the deterioration of a member's condition. The category 2 services are meant to enhance the effectiveness and improve the category 1 services. So we have things like nutrition education, goods, kitchen supplies, transportation, things other than food. There's a few rules around these that I will share. So for one, as we talked about, each ACO will have to offer 2 supplemental services, one in housing, one in nutrition. In nutrition, now you see we have this category 1 service and a category 2 service. An ACO must offer a category 1 service to offer a category 2 service. It's great to get transportation to a grocery store, but if you do not have the funding to buy something at the grocery store, then we haven't really solved the problem. So we really want to make sure that you're giving food as well as additional access that enhances that food. A member can only receive one Category 1 service at a time. Okay, so Section 2, medically tailored meals. Each section is broken up into very similar subsections. So with medically tailored meals, I'm going to go into more depth and description here so folks can get a sense of readability, of what to expect in the sections, and then we'll go a bit more quickly through the other sections. So in this section 2, you have service description, you have additional service detail, which doesn't exist in every section, but most here. You have individual or household, which you'll see in nutrition, particularly in Category 1 services, but not in housing or Category 2 services. You'll see eligibility, meaning enrollee or member eligibility, provider qualifications, and then payment guidance and billing code requirements. Once again, we'll go through medically tailored meals in a bit more depth so you get the idea and we'll be able to read then the other sections. So section 2.1, this is really the service description. This is the standardization piece of what it means to provide a service. And it lists out in detail what it means for medically tailored meals and all of the other services likewise. For medically tailored meals, this means that you're getting a fully prepared meal that's approved by a registered dietitian nutritionist. And the key point here that the food is nutritionally appropriate. It's based on the enrollee's medical diagnosis, and that is evidence-based practices such as the dietary guidelines for Americans. So the food that you're getting is really based on the research and based on the member's needs. You can get up to 3 meals a day, 7 days a week in this service, and the members must be offered at a minimum 12 weeks of service. And then at 6 months, a maximum of 6 months, the member must be re-verified, determined if they are continued to be eligible from a service standpoint. There are 2 other pieces of this service that are included, which are included in most Category 1 services. One is navigation, and 2 is information about the service. So we'll start with navigation. And actually, to start with navigation, we'll take a quick step back. It is important to know that included in this service, and its rate and its build-up, and every service is the expectation that the provider will assess the member's needs and make a plan with them. Here, for example, a member may be referred for medically tailored meals. They may meet with a registered dietitian nutritionist, and that RDN will sit down with the member, figure out the member's needs, and create a type of plan with the member for the services. That would be included in your price. That is something that you all likely do now, a little bit different from each service, but that's wrapped in to the amount. So we don't call it out here, but what we do call out here is navigation. So during that time period where the RDN in this case is doing this assessment, if they determine there are other needs that they cannot meet, for example, that the member is not on SNAP but would like to be on SNAP, the HRSN provider is required to navigate the member to the service. They can do this in one of 2 ways. One, they can go right back to the ACO. They can say, ACO, we have identified this other need. This came up. We need you to help us handle this. You go and handle this, and that would be perfectly appropriate. Or if the ACO and the HRSN provider determine that the HRSN provider should handle it, maybe the HRSN provider is also a SNAP provider or knows of a SNAP provider that they could move along. Even better, third option is that you're really working together as a team and communicating so that we know where the member is going and the member gets the services they need. So just a clear note on navigation that it is fine if the HRSN provider cannot provide that navigation. The navigation would be back to the ACO. And then the third piece is this medically tailored home delivered meals information. And this exists for every service in the category 1, almost everyone. And this is a bit of information about what you are receiving. For example, you could have a fact sheet about the benefits of protein if you're getting a lot of protein in your meal. Okay, we're going to scroll down just a little bit and talk about eligibility rules here. And this particularly, again, is service eligibility. So we're not talking about, is the member a MassHealth member here? We're talking about that slide that showed the 3 columns. Are they hitting each column? And then remember I said that some services, this one is one of those, may have a little bit of a different eligibility or an enhanced eligibility rule. And so we see that here. So in this situation with eligibility, what we have is 1, that the member is indeed in an ACO, 2, that the member has a health needs-based criteria. But in this particular case with a health needs-based criteria, we actually have 8 particular health needs-based criteria that we have called out that are eligible for medically tailored meals. So it is HIV, and we'll scroll a little bit down more to show this. HIV, cardiovascular disease, diabetes, renal disease, lung disease, liver disease. It's all in, I'm saying it fast, but it's there. Cancer, high-risk pregnancy. So you have all of those. ACO, one of the 8 HMBCs. Member must meet the risk factor of food insecurity and be unable to prepare their meals. One important call out here, see definition section. There has been an update to the food insecurity definition. CMS is working across states to make sure that we have consistency of what these definitions mean. So we will now be using the definition that comes from the U.S. Department of Agriculture. Someone who is experiencing food insecurity has very low or low food security. All right. I know I jumped a little bit to eligibility, so I'm going to just take us back to where you see on screen for a second and talk about when you need to check for service eligibility. This is in this additional service detail section, and it exists like this for all of the services. So we'll go through it once, and then hopefully you can read through and semi get it. So the responsibility of checking for eligibility is with the plan. The plan can designate that eligibility check requirement if the designee agrees to it. So for service eligibility, you need to check before the service is given, when a service period ends, and for category 1 nutrition services, 6 months into the service period. It doesn't mean that at 6 months, the service has to end. It means at 6 months, you have to check again for eligibility and make sure that the person is still eligible and can continue getting the service, or maybe at that point they need a different service. One other piece here you'll see in section 2.3, we have the opportunity to give services to an individual or the household. This means that if a member alone needs a service and qualifies, they can get the service. If the member is part of a household, see definition section, then that household could also potentially get that service if the ACO has selected that as a service. To do that, the actual individual must be a high-risk child or a pregnant individual with a health needs-based criteria. All right, so we're a little out of order. I'm sorry about that, but we're going to scroll down to provider qualifications and talk for a moment about that. So our provider qualifications for nutrition look very similar over category 1 services. So I'll go through them here, and then you'll see a lot of similarities in these other services and little nitpicky differences. So look out for those. But in general, what we're talking about here is the organization, the entity's overall qualifications. So the entity needs to have at least 1 year of experience providing here its medically tailored meals to persons experiencing food insecurity with applicable health conditions. They need to have specialized staff with knowledge of medically tailored meals and food insecurity or imbalance. They need to have staff that has education and training on nutrition or anti-hunger services or relevant professional experience or lived experience, and have an RDN or on staff or as a consultant to assess enrollees and approve meals. And this changes a little bit per service, but generally these are our qualifications in the Category 1 services. So let's go ahead and scroll down to our payment section. All right, a little plug here. On August 6th, we are having a Claims 101. It is centered for potential HRSN providers. All are welcome. We put the invite in the appendix. Please sign up. If this chart looks a bit confusing to you, if you're not really sure what HCPCS code is or what is going to happen with all of these numbers on the page, this Claims 101 is for you, and we'll hopefully be doing a 201 at a later date. But for now, big takeaways. For nutrition, MassHealth is not setting a price that plans must pay providers. This is true across the board for nutrition services, whether it's Category 1 or Category 2. It's different for housing, and my colleague Emily Cooper will speak about that in a few minutes. Instead, we are providing reference information to help plans and HRSN providers in negotiating a rate. Within this rate that we have given here as a reference, we have included the whole package. So in this case, you would have meals, the staff time, the delivery, the meal planning assessment, and admin. It's a comprehensive price. And we provide a range here as well as a midpoint. We did extensive research. We used historical flexible service data. We looked at the Bureau of Labor and Statistics, wage estimates. We took stakeholder input and did additional market research to get to this point. So when you come to the Claims 101, you'll learn more about all the nitty-gritty, but those are our main takeaways of what you can take from this chart today if it's a little bit muddled. All right, so we're going to scroll down to section 3. And so we made the big one. We kind of walked through what this service manual looks like and how it's set up. And now we're going to kind of move quickly through these other services, and I encourage you to read them. I hope you already have and have lots of questions for us. That's why we're going to move this quickly. All right, so next up, what we have is a nutritionally appropriate home delivered meals. So in this case, HRSN providers provide meals to enrollees that are home delivered, they're nutritionally appropriate, healthy, well-balanced, and approved by an RDN. Again, it's the same general principles of medically tailored meals, with the exception that they're not based on a medically tailored condition. They're based on a health needs-based criteria, not just those 8, but any health needs-based criteria. The rules parallel the rules above pretty much. We just changed that we don't have that 8 conditions. We also don't have a minimum of 12 weeks, but you do still have that maximum of 6 months before re-verification. All right, see, told you we would speed up. Section 4. Okay, medically tailored food boxes. And you're going to see the same parallels that we just did for medically tailored meals, now for food boxes and for food prescriptions. So we have a medically tailored one, and then we have a nutritionally appropriate one. And in general, the medically tailored one uses the health needs-based criteria for 8 conditions, whereas the nutritionally appropriate one is broader. And so that the general parallels will exist. So just as we have with meals, we're going to sort of go through just a little bit, but again, a little faster to keep us moving. So we have medically tailored food boxes in section 4, and in section 5, we have nutritionally appropriate ones. Providers of medically tailored food boxes, they're offering minimally prepared grocery items. It's approved by an RDN, and it's looking to help a member that is experiencing food insecurity get appropriate nutrition to support one of those 8 specific health conditions. Again, we have that 12-week minimum and then the 6-month re-verification. The major eligibility difference here, besides the 8 conditions in a medically tailored one, is that for these services, we need to make sure that the member has access to the box. It's not a meal that's home delivered, so we have to think about how is the member going to get access to this service, and this is true for the mainly the rest of our services. So with this, we need to make sure that a member has access to transportation. And so an ACO will either need to have a way to give members access, or they will have to actually provide the nutrition transportation service, which is our Category 2 service. One other piece here is that because it is a box and not a meal, a member must be able to actually make the meal or have a authorized representative or guardian that can make the meal. Otherwise, they're going to need an actual home delivered meal. So we're going to scroll down now, let's see, make sure, to the top of page 10. And make sure we get all of the things. This piece for you gives you about the transportation piece. Again, we have some information about individual versus household, same as before, as well as the eligibility. And this is all, again, the medically tailored box. And then section 5 shows you a very similar layout of the nutritionally appropriate box. Same idea, biggest difference in the nutritionally appropriate box, you don't have those 8 conditions. It's the larger health needs-based criteria. All right, so we're going to go to section 6, and that is our medically tailored food prescriptions. So this is actually a new service from what we showed you back in April. If you were with us then, we showed you this list of services in a different form, not yet a manual, but now we have also added a medically tailored food prescription, just like we have for the food boxes. We have one that's nutritionally appropriate, one that's medically tailored. We're doing the same thing here, the same parallels. So a medically tailored food prescription is when an enrollee receives a voucher or a grocery store gift card to purchase minimally prepared grocery items from an allowed list that's created by an RDN that's tailored to the enrollee's medical condition, one of those 8 conditions. We're calling this list an approved purchase list. It's got to be offered again for that minimum of 12 weeks and re-verified again at that 6-month period. We have in these services, and we also just, as I mentioned, in the section 4 and section 5, the requirements of navigation, requirements of information for these services as well. Everything else pretty much parallel and the same. And then when we move down to section 7, what we'll see is nutritionally appropriate vouchers or gift cards to enrollees with food insecurity to meet the needs to meet their needs for getting the nutrition that they need. This is not based on one of their medical conditions, although again, they need to meet a health needs-based criteria. So again, a little bit more expansive, not one of those 8 conditions, one of many health needs-based criteria. You have in this service navigation requirement, but you don't have a requirement of information, and you don't have a minimum of 12 months, but you do have that 6-month need to re-verification. All right, we're going to actually scroll the payment section on this one because we have one minor update. All of these payment sections sort of look the same, have the main takeaway message. We have one minor update in the unit price. The midpoint and the ranges for both are the same, except the corresponding to gift card should be $90, not $100. And we'll be doing an update, as I'm sure many updates to the manual to reflect that, but just making sure people know that today. All right, let's keep going. We're almost, we're done with our Category 1 services. So these are the services an ACO has to offer, at least one of them. They want to offer a Category 2 service, they have to be offering a Category 1 service. All right, so the first service we'll talk about here is application assistance. And here providers support enrollees to obtain discretionary or entitlement benefits and tax credits. This may include helping an enrollee fill out an application, monitoring an application process and status, helping gather documentation. For all of these Category 2 services, plans must account for enrollees who may not be able to access service due to lack of transportation. So similarly, what we just talked about for all of the services besides the home delivered meals. We need to figure out, is there a way for the enrollee to access the service? Is there a virtual option? If there's not, then the ACO, the plan, needs to go ahead and offer the nutrition transportation service. And to be eligible for this service, the criteria are a little broader. You need to have that health needs-based criteria, experiencing food insecurity, and be receiving a Category 1 service. I'm not going to go through provider qualifications, but some of those change up a little bit more. Just a note on how these services are billed. These services are more billed in 15-minute increments, so you could do 15, 15, 15, or whereas some of our other services are about a meal box, a meal, etc. All right, we'll move down to section 9. And then in section 9, we have benefit maintenance assistance. This is about helping enrollees experiencing food insecurity obtain assistance with maintaining access to nutrition. So this is specifically to nutrition, whereas the other one is broader. And this is in the form of coaching, supporting, educating enrollees. You might also support with SNAP or WIC. It also includes support with nutrition benefit action. So if there's a denial or reduction or termination of services, this would be where you could go. This is not a legal assistance. Come on. All right, I'm going to keep going so we get to housing. So almost 3 more. In section 10, we talk about nutrition education classes and development. And here enrollees will receive support in the form of either group classes, one-on-one sessions, or educational materials. Big note here is nutrition educational materials, and juxtaposing that with this material information that we've been talking about for the Category 1 services. The nutrition education materials here, this is its own service. It has to be more intensive and not duplicative of the nutrition information provided in Category 1. So it must extend beyond the foods that are being provided with the services. It may include, but not limited to, things like food storage and preparation, tips for shopping in a market, nutrition information related to the applicable health needs-based criteria. And then just a note here in the payment section, in the payment charts, you'll see that the payments are broken down by these sub-services. So we have that class, the one-on-one sessions, the materials, an ACO can choose to provide one of these types of sub-services or all of them. So you're not necessarily saying, okay, if I do nutrition education, I have to offer all 3. So 11, section 11. This is nutrition counseling, so it can be provided one-on-one or in a group setting with an RDN. To receive this service, again, you have to have health needs-based criteria, food insecurity, receiving a Category 1 service, and actually be assessed by a provider that you need this service. All right, section 12, kitchen supplies. So this is where providers are going to pay for and assist enrollees with obtaining cooking supplies. So it's everything from your air fryer to your blender. We've had a lot of air fryers in flexible services, and help meet those nutritional needs. So it's great if you have a food box and want to make some smoothies, but if you don't have a smoothie, we've got a problem. So again, enhancing these services. And last one before I send it over to Emily is nutrition transportation. We've been talking about this throughout. This is the service where you come when you don't know how else to get access to your member to transportation. You are asked to arrange or provide public or private transportation for an enrollee who needs assistance getting to either a Category 1 or Category 2 services. So in this case, as we've talked about, if you're picking a Category 1 service, if you're picking a Category 2 service, you the plan must consider how a member is going to access it. You can't figure out how they're going to get it. It's not a home delivered meal. It's not a virtual option. You would come here and you would pick a nutrition transportation service. All right, a lot in a very short amount of time. Again, it's all there for you to read through. I'm happy to take questions at the end. for now, I'm going to pass it over to my colleague, Emily Cooper, so she can talk to you about housing.
Thanks, Stephanie, and you can go take a well-earned break. I will try and talk as comprehensively and eloquently as Stephanie did about nutrition, about housing services. And we will also be walking through the service manual. As we noted, it is online. Hopefully you guys can join along in looking at it, because I'm not going to mention every word. I do want to stress a few things. As Stephanie mentioned, the definitions section includes definitions for housing services. So if you're going to say, oh, who's homeless? What does unhealthy housing mean? And the reason, as you read through this service manual for housing, you'll see capitalized phrases or clauses or words. Those are ones that are defined in the definition section. So keep that in mind as we walk through. I'm sure that some of the questions you're going to ask me might be answered by looking at the definition section. So just to keep that in mind. I also want to just remind folks, because you just heard a lot about nutrition, I want to back up for a second and remind you that of these 5 housing services, accountable care organizations, or ACOs, the health plans, get to choose which ones they want to provide. And they have to provide at least one, but they get to choose which of the 5. They also get to choose which agencies that they want to contract with, included in the when I go through the provider qualifications, they get to choose, of all the qualified providers or agencies out there, which organization they're going to partner with. So just because we're going to talk about these services doesn't mean that every ACO is going to choose to provide them. It also doesn't mean that every ACO is going to contract with your agency if you're the provider to provide them. So I want to keep that in mind. Okay, so we're going to scroll through this. We're going to start with housing search, which is section 2. Housing search, for those of you who do housing search, it's spelled out really clearly here, but includes talking to the person, figuring out what they want and what's available, including helping them figure out if they need to apply for more income or become part of the coordinated entry system in the area, helping them, once they've located housing, move in, coordinate all parts of signing a lease, figure out where you're going to get furnishing and furnitures and move-in costs, securing utilities, if they need a home modification or something like that, getting that in place. And then there's limited housing stabilization, which is ensuring that they make timely rent payments, coaching on life skills, and providing referrals to community-based organizations. I want to flag that we already have a housing search program called Specialized CSPHI, or CSPEC, sometimes it's known as, and this is different. This service is for people who are not eligible for CSPHI, and it is heavy on housing search and light on once people move into housing. So it serves a slightly different population. And given that, we recognize in section 2.2 that the services might ebb and flow, right? If you're working with somebody who has needs housing, you're going to help them fill out all these applications, and then they might wait. They might be on waiting lists, and then they might get off a waiting list and you help them again. So the services might ebb and flow, which is why we feel comfortable with an average caseload, as you see in section 2.2, of 1 to 35, with check-ins at least twice per month, recognizing that some people will need more services in some months and some people will need less. So that is sort of the design of the housing search services and the caseload. Now, who is eligible for the service? Scroll down, please. Thanks. In section 2.3, it needs to be, as Stephanie said, all these services, the person must have a health needs-based criteria. If you don't know what that is, it's in the definition section. They must be experiencing homelessness. That word is capitalized. It is defined in the definition section. And just to give you a precursor, that definition relates to HUD's definitions of the categories of HUD's definitions of homelessness. Because this is similar to CSP for homeless individuals, you can't receive both of this and that. So if you're eligible for CSP for homeless individuals, then you're going to get that. If you're not eligible, then you might be eligible for this housing search program. You can't also be receiving housing search assistance as part of EA or home base in order to receive this service. So you need to be homeless and not receiving CSPHI and not receiving similar housing search services as part of the emergency assistance or home-based programs. that are run by the Executive Office of Housing and Livable Communities. That is who is eligible, and have a health needs-based criteria. For your agency, if you're thinking about, wow, you're describing people I serve and services I do, in order to be eligible and to contract with a health plan and accountable care organization to do this, you must have at least 2 years of experience providing housing search supports like this to people experiencing homelessness, which must include having current contracts or grants with local, state, or federal agencies to assist people experiencing homelessness and locating housing. It must also include that you have training on how to document and determine homeless status in accordance with the federal HUD requirements. You also have to have experience providing services in different areas, and you have to be a documented member of the continuum of care planning groups that are within the service area where you're going to provide these services. If you're not familiar with continuum of care, again, that's a defined term that is in the definitions section, and it is a homeless planning group. There are 11 of them across the state, and you need to be a member of the continuum of care planning groups in the area where you plan to provide these services. You also need to be knowledgeable of coordinated entry, also defined in the definition section, that each continuum of care operates so that you would be able to help somebody access the local continuum of care coordinated entry system. And last but not least, you now have to have staff that it really knows about how to do housing search, helping with applications, requesting reasonable accommodations, clearing criminal records, dealing with credit histories, negotiating lease agreements, etc. We do provide at the end of the service manual a list of agencies that are currently providing services similar to housing search, and that's mostly for health plans to get the ball started, if that's helpful. These are ones that are currently either participating in flexible services or participating in the CSPHI program. Next section, please. So the key point to these charts, lots and lots of information on here. I want you to look all the way, I guess, to your right where it says unit of service, price per unit, and maximum limit of service. So the bottom line is to provide this service, if you provided this service, a health plan will pay you no less than $400 per month per person for up to 15 months. That is so if you had a case rate if you're serving 35 people, it would be 35 people times at least $400 a month for up to 15 months. And the up to 15 months depends on how much they need for assistance. And that would be per person. And then you'd have to meet the requirements. Again, some people might need more or less help in that month, depending on where they are in their housing search process. That is housing search. 1 down, 4 to go. Next one, transitional goods. So once you find the housing, you often need things like a security deposit or a first month's rent or a shower curtain or a table or a bed. And so that's what transitional goods does. It provides moving costs, furnishings, and other items for people moving from homelessness into housing. And so I'm gonna stop here for a second and ask the folks manning the screen to press on that attachment B, which is embedded in here. It's going to take you to another section, maybe, of the guide. Maybe just go to attachment B, thank you. So this is the exact list of allowable transitional goods. If it is not on this list, it is not eligible. So it runs from air conditioner, baby necessities, bath towels, bed frame, birth certificates and social security card fees, to coffee makers and dishcloths and housing deposits, as you see there, housing application fees, knife sets, laundry baskets. It's pretty extensive. Keep going down for me. Microwaves, shower curtains. Want to flag utilities here, includes utility setup fees or deposits, and then up to 6 months of utility, either arrearages or utility payments, window shades, waste baskets, trash cans. It's a very exhaustive list. It is the exhaustive list. It is on the list, you can buy it. If it's not on the list, it's not considered eligible or allowable, excuse me. So I wanted to flag that. If you can head back to section 3 for me. Sorry to make y'all dizzy. A little bit up, thanks. So what transitional goods are for people experiencing homelessness who are moving from homelessness into housing. And in order to get transitional goods, you need to either be getting housing search services, which we just went through, or the specialized CSPHI, which is another type of housing search. So if it's for people who are receiving services already by a housing search provider or specialized CSPHI provider, once they find housing, if the ACO has contracted with you or another agency to provide transitional goods, you can help this person buy and procure, obtain transitional goods. So scrolling down a little bit under eligibility, as I mentioned, you have to be eligible. It has to be moving from homelessness into housing and receiving one of the other MassHealth services. So the people who are eligible, the agencies that are eligible to provide and buy the transitional goods on behalf of folks are those who are eligible under housing search services that we just went through under Section 2, or receive our specialized CSPHI services. Going down a little bit, for payment, again, we're going to look all the way over to the right. You can spend up to $5,500 per person per transition from homelessness into housing. So that list of all the allowable items, somebody can buy. You can work as a provider, you can work with a member on housing search, and then the transitional goods would be up to $5,500 to spend on items that are on that list when they move from homelessness into housing. If at some point in the future they lose that housing, they wind up homeless and eligible again and receiving these services again, then you would be able to provide another $5,500 when they locate housing and move into that housing again. So that is Section 3. Okay, so that was services for people who are experiencing homelessness. Now we're going to look at people who are housing unstable, people might say at risk of homelessness, and what we have designed is something called housing navigation. What you are trying to do is get them to the place to address the issue they're having. And they may be having an issue with a landlord, they may be having an issue where they don't have enough money, they might need legal assistance, they might need to apply for new housing, whatever it may be, you're going to navigate them to that and have a warm handoff. So you might help them fill out applications to secure needed documents or submit applications for resources to increase their income. And some are here, tax deferral, discount utility programs. You might help them apply for subsidized housing. You might help them apply, include to be part of the continuum of care coordinated entry system. They might have issues right now with their landlord, so you're going to help with get them services around mediation. They might need to request a reasonable accommodation or establish a payment plan. They might need help with legal assistance. Now, you're not going to be a lawyer for them or represent them in court. You're going to connect them to the legal assistants who can. Or maybe their housing is really poor and they need somebody, the local housing quality agencies or home improvements to come in, or to even work with the landlord around this. Maybe they need help reestablishing their relationship with or establishing their relationship with MassHealth, other services, or other state resources that might be able to come in and help make sure that they need help maintaining their housing moving forward. Next, scroll down for me, please. Thank you. So again, similar to housing search, there's an average caseload of about 1 to 35. You have to check in with the person twice a month, and you can provide services in a variety of settings. You may be able to, in addition to the services, just flagging at the top of this page, if somebody needs to move to a new housing location, there is limited amount of funds that but there are funds available to help them with housing application fees and background checks and identification documents. So things that small costs that may come up to help somebody move. So who's eligible? Well, they have to have a health needs-based criteria. And we have a similar program called Specialized Community Support Program Tenancy Preservation Program, or CSPTPP. CSPTPP is specifically for people who are being evicted. An eviction is a very specific legal action. So they are in housing court, they have gotten a notice to quit. The people who are eligible for this service haven't gotten to that point in their journey, and hopefully won't get there with your assistance. And so this is before, maybe they got a lease violation, maybe they have non-payment of rent, maybe they've missed some rent payments, or their landlord has just yelled at them, whatever it may be, their housing is at risk, but they are not being evicted. If they're being evicted, then they would they would be eligible for the CSP TPP program. This is for folks whose housing instability is not at that point yet. And again, we hope it doesn't get there, but if at some point this service didn't work, they could go on to the TPP program. So somebody asked in the questions, do we have a definition of at risk of homelessness? And we don't, because it's not capitalized there. What we have here is at risk of homelessness. We know what homelessness is demonstrated by not having sufficient resources or support networks to immediately prevent a person from moving to an emergency shelter or an unsheltered situation. So that's the first thing. This person will lose their housing imminently. And so they without assistance, they will wind up in a shelter or place not fit for human habitation or unsheltered. There are many people who are in bad housing, who are in inaccessible housing, and we're going to talk about those in a second. But they're not at risk of losing it. They're just in yucky housing. So this is for people who are at risk of losing it. And that means specifically that they are doubled up. And we do have a definition, see it's capitalized, doubled up. If you look in the definitions, they're living in and paying for nights, or they're living in and paying for nights in a hotel or motel, or they've received at least one written lease violation, they have missed one or more monthly rent payments, or they're living in unhealthy housing, which we have defined in the definitions and can't be addressed by any of these other HRSN services I'm going to talk about. That's specifically who this is for. And for the service providers who can provide this service, you need to have experience at least 2 years providing these kinds of supports to this population, including current contracts or grants with local, state, or federal agencies to assist people to apply for public benefits, housing, income maximization resources. You also, similar to Housing Search, must be a documented member of the continuum of care planning groups within your service area and able to connect that person. You don't have to assess them. You're not doing the coordinated entry assessment, but you know what coordinated entry is, and you know how to connect the person you're working with to the coordinated entry system in their continuum of care. And then last, but definitely not least, is you have knowledge of this area about how to complete applications, how to get people better income, how to do reasonable accommodation, negotiating with landlords, etc. So next section, please, is the payment. Okay, again, scrolling all the way to the right, we actually have 2 rows. The first row is how much you get paid for staff time. So again, it's no less than $400 a month, per month for up to 8 months. And so that is, and it doesn't say it's even 8 consecutive, it's just 8 months. So if you are working with 3 people, it'll be 3 people times at least $400 per month, and then up to 8 months. In addition, while you're working with someone, you need to help them relocate they've found other housing, and there are costs related to that, which have to deal with housing applications, getting a criminal record check or a credit check, those things that landlords might charge you. You can spend up to $100 total per year on those kinds of expenses if someone is relocating as part of keeping them stable in and preventing homelessness. Okay, I only got 2 more to go. I hope you're with me still. All right, so that was for people who are housing unstable. Section 5 and Section 6 are for people who are stable in their housing. They're not going to lose their housing. They have the resources to live there and pay the rent, but that housing isn't great for them, either because of their health, their medical condition, their accessibility needs, the condition of the unit. And so it's not a great place for them to live, but they're not at risk of losing it. And so that's the difference here. So healthy homes, as we call it, is goods and remediation services to help improve the housing conditions and that are affecting your health or the person's health. These cannot be, just so you know, things that the owner or landlord should be responsible for. So like if there is no heat, you're going to be talking, you're going to be under, you're going to be talking to somebody else. You're not going to be getting healthy homes, because no heat is a requirement that the landlord or owner needs to address. So this includes specifically goods or remediation services. Of note, if you're a flexible services provider, this all used to be bundled under home modifications, and we have separated it out because we feel that they are two distinctly different things. So under healthy homes, you can buy an eligible person one of these specific things. Similar to transitional goods, this is an exhaustive list of allowable items. So things related to air quality, so you can buy them an air conditioner, purifier, cleaning supplies, curtain blinds, dehumidifiers, HEPA vacuums, fans, HEPA filters, and hypoallergenic mattress and linens. Medical storage, you can buy them a refrigerator for their medicine, or sharps containers, or even trash cans with lids. And pest control, you can buy household pest eradication products, and then trash cans with lids in general. In addition, if that person needs some sort, that their housing, you can't just buy them something. There is something else going on in their housing that needs an actual remediation service. You can go in, conduct a home environmental risk assessment, and then arrange for remediation services that could be, for example, related to air quality or pest control, like carpet removal, mold remediation, vent cleaning, pest eradication, chore services, including heavy house cleaning, removal of hazardous debris, direct and removal of yard waste, things like that. So it is goods and it is services that people might need because their housing, and I just want to say it's unhealthy or it is yucky. Yucky's my word. So let's see. Under Section 5.2, you could receive both. You might need an air conditioner and your carpet cleaned. For remediation service, you could also be a provider who just does the goods. But if you're going to do the goods and the remediation services, then you're going to have to do an in-home needs assessment, which says what type and amount of services that person would need. Do they need carpet cleaning? Do they need mold remediation? So you actually need to have staff who's able to do that. So as I mentioned, a provider could choose to do only goods or both goods and remediation services. But if you do remediation services, you're going to need to have staff who is qualified and knowledgeable about doing an in-home needs assessment. You also might do an in-home needs assessment and find, gosh, we could buy whatever we want and clean whatever we want, but this housing is just not habitable. And you might then refer them to housing navigation services so they can address how they might find another place or talk to code enforcement. Next slide, please. Or next, thank you. So who's eligible? So you have to have a health needs-based criteria and be living in unhealthy housing, which is defined in the definition section, or housing that's physically unsafe due to your disability or medical condition. And who can provide these services? You must have knowledge of the things that we've asked you to do under healthy homes. And if you were going to do the remediation services, you have to have staff that has experience conducting in-home environmental risk assessments. We did provide, again, a list of agencies who have done similar things in the past for MassHealth. And I forgot to mention on the slide before that we did that. We gave folks a list as well for the housing navigation. So for the payments, again, we have goods and services, and we got a whole bunch of other things here too. So you can spend on the top row up to $750 total per year helping a person buy, buying a air conditioner, let's say, or a HEPA vacuum, whatever was in those allowable items. So up to $750 a year for the allowable items. You as a staff person can be paid no less than $150 each time you help that person purchase, deliver, or install that air conditioner. So if you get an air conditioner and then you go to Lowe's and you're getting them a HEPA vacuum and you're bringing it back, each item that you purchase up to the $750 per year is $150 of your time minimum to help with the purchase, delivery, and installation of that. For those in-home in-home environmental assessments, you can have one per year for no less than paid no less than $250 for that in-home environmental assessment. And then the next slide, please. And go down, thanks. And then depending on what is needed, let's say it's a carpet cleaning, you could spend, you could pay a contractor for up to $5,000, excuse me, to do that carpet cleaning a year. Or maybe it's vent cleaning, or maybe it's cleaning the drapes, or carpet removal. All of these things must happen with the consent of the landlord, assuming this is rental housing, but you can have remediation costs of up to $5,000 each year. And then your time coordinating with that carpet cleaner agency or Serve Pro or whoever you're using is $200 per remediation service. And then I swear this is my last one. Okay, so again, people living in housing that is not appropriate for them given their needs. So in this case, this is a person's primary private home that is not accessible, and we're going to make a physical adaptation to the unit so that they can use the housing more independently. And this also cannot be considered the responsibility of the landlord. And we gave you some examples of common home modifications. So this is a physical adaptation of the housing. I like to think of it as we're sticking a nail and a hammer in a wall. And there are three components of it. The first is a needs assessment, where we're going to stay with the person in their home and watch them use the home and figure out what they need done so that they can be able to do their activities of daily living and instrumental activities of daily living. And this needs assessment could be completed by the health plan or by a provider, but they need to complete it visually with the person to see how they use the home. The needs assessment would also determine if, gosh, we don't really need a home modification. All we need is a grab bar, which is durable medical equipment, and we'll install that in the wall and build that to durable medical equipment. Assuming that they actually need a new ramp or a widened doorway or something like that, we're going to develop a home modification plan. Scroll down a bit for me, please. And that includes a recommendation of what you're going to do to the home in order to make it more accessible. So specifications of the proposed adaptations, including a drawing of what the person is going to do. You need to get approval from the property owner for the modifications. This may include submitting a request for a reasonable modification to the landlord to allow this under the fair housing laws, and includes identifying a home modification contractor and obtaining quotes from them for the cost of completing the modification. You also have to think about in your home modification plan, where's that person going to live while you're modifying the home? Can they stay where they are? Can they move to a slightly different part of the house? Where are they going to be so that they, can they live there peacefully while the home is being modified so that they're not becoming homeless? Scroll down for me, thanks. And then the last thing is construction supervision. So we have a plan, we know what we're going to do, we have a contractor, we've contracted with them, and now the supervision is I'm showing up at the work site and saying, is this on time? Is this on budget? Are you doing what you're supposed to do? So the construction supervision must be completed by, and overseen, the construction must be overseen by the provider. So just a few notes, this one's a little bit more complex, so we have a few more notes on what you can and can't do in home modification. So the first thing is this has to be in private housing that the person owns, rents, or leases, and it's the primary place where they live. This isn't like their secondary home or something like that. You again must have to get approval from the landlord owner for these modifications, and the contractor that you contract with must be licensed and must be able to get permits and meet all their local and state business license and a few other things if they're going to do a lift, and they must have tradespersons who are applicable to the trade that you're not going to hire a plumber to do an electrician's job. There's also a list that I'm not going to go through here of things that are not considered allowable home modifications, but they often relate to recreation or general home improvement or parts of that, doing something for part of the house that the person doesn't get involved with. So feel free to read through this, and there's a whole bunch in there that are not considered home modifications. So who is eligible? They must have a health needs-based criteria. They must have a primary private home that is inaccessible housing, which we've defined in the definition, or physically unsafe due to their disability or medical condition. Who can provide these services? You're not required to do all three things: the needs assessment, the development of the plan, and the construction supervision. But you need to meet the provider qualifications of the thing that you are going to do. So if you're going to do the needs assessment, then you need to have staff that is trained in mobility and accessibility assessments, knowledge of the fair housing laws, knowledge of reasonable modification requests. That could include staff from the health plan, or it could include staff from a community-based organization. If you're going to want to develop the home modification plan, then you must have staff with skills in home modification design, knowledge of standards around access and mobility, and knowledge of standards of construction codes and standards in Massachusetts for residential construction. And then lastly, if you're going to supervise the construction, you must have a general contractor licensure, architect certification, experience in construction, knowledge of accessibility and universal design, and experience doing these small scale rehab. So I want to just flag that attachment F is a list of agencies that are participating in the Massachusetts Home Modification Loan Program, which is a program that already runs here in Massachusetts, and those that have been procured by the Massachusetts Rehabilitation Commission as a home modification contractor. And there's a link. That list is ongoing, and so we downloaded it from June 2024, but there are contact people there that you can go and visit if you're saying, oh, this is something I want to do, but I couldn't even tell you where to get started and who could do this. Scroll down for me, and I swear this is my last page, but it is a little complicated. So here's the payment. Again, columns over on the right. First row is the needs assessment. You're going to go doing the needs assessment, and you would get no less than $500 for that needs assessment, and you could do that once per year. You're going to develop that modification plan, develop the home modification plan for no less than $800 once per year. And then you're going to oversee the construction supervision. You're going to oversee the work that's done for no less than $800 per year. Thanks. And then you're going to pay a contractor for the home modification. They're, the people who are putting the nails in and building the ramp or whatever that means. And that would be up to $10,000 per year. I think that brings me to the end of my services. So I'm going to stop here and turn it back over to Stephanie. And look at all those questions that you guys probably put in the chat. So thank you for your patience.
We're hitting record numbers of questions. So
okay, I'm gonna start trying to tackle those. Okay.
Yep, our document is full, so I'm going to try to go through these other pieces quickly. Again, as I mentioned earlier, lots of information we're covering. We're trying to cover a little bit more information here, but we will have opportunities to talk about this more in other settings. We just wanted to ping a few pieces. So with that, we'll jump into this network adequacy section. You can read on your own. Large takeaway about network adequacy is that HRSN providers, this is not your responsibility. This is solely the responsibility of MassHealth and the plans, not the providers. The goal of network adequacy is to ensure that enrollees receive adequate access to care across all geographic areas. And that's the basic 2 points you want to keep in your mind. We can go to the next slide. Ensuring network adequacy and health-related social needs, supplemental services. As we discussed at the beginning, we are going to be going through this transition. And we're going to try to work with folks to make this transition as smooth as possible. For 1/1/2025, the rule that the health plans will need to follow for network adequacy for HRSN supplemental services is that ACOs must contract with at least one HRSN provider located anywhere in the Commonwealth to provide services. If that one provider is not enough to ensure timely access to services to the members, they must contract with more. Lots more there. Those are the two main takeaways so that we can keep moving onward into provider credentialing. Another quick plug for our webinars. We have done a webinar on provider credentialing. If this is new to you as a potential HRSN provider, encourage you to watch that series. All right, so to provide HRSN services, HRSN providers must be credentialed and enrolled as a network provider, either with an ACPP or MBHP. And there are certain standards, credentialing rules that apply when generally a provider is going to provide services. But for HRSN, it doesn't quite fit. And so what we have done here is identified for you all, whether you're an ACO, MBHP, or an HRSN provider, what areas you actually do need to provide to be credentialed, and what areas don't actually you don't need to provide because they're just not applicable to you. You can read this in detail. One note on credentialing, I think it may be on our next slide, but just in case, oh no, it's right. Last slide, please. I'm sorry. One note on credentialing. We talked about to credential, remember you need to get an MPI number. If you are a behavioral health vendor or a behavioral health provider, those seem to be our most likely folks that cross over, maybe others that do behavioral health and likely will do an HRSN service. We strongly encourage you to get another MPI number so that you will have 2 MPI numbers for the different types of business that you are providing. If you are doing HRSN services already and have an HRSN service MPI number, essentially, you don't need to do this. But if you are going to be new to HRSN services and have a separate MPI for something like behavioral health, we really encourage you to go ahead and get that new MPI number. All right, next slide. There are certain forms that most plans use to help fill out for credentialing. And here we have taken the most standardized form that was created by Healthcare Administrative Solutions with the plans and kind of clearly noted where we think it's not applicable for HRSN providers, and plans should not be requiring HRSN providers to fill out those areas. So what we have done here is essentially boiled down to these are the things that are needed in general for credentialing of HRSN providers. These are the things that are not needed. There may be other things. This is not an exhaustive list, but we tried to catch all of the big ones to make it a little bit easier for folks on both sides for credentialing. In the interest of time, I'll let you read all of those pieces offline. All right, and we'll talk about hubs for a second. Again, another good webinar to listen to, but just a little bit of background. What is a hub? A hub is made up of 2 entities that come together, a parent entity and a satellite entity. The parent entity is the one that contracts with the satellite entity, which is the HRSN provider, and then contracts with the plan and really performs all the administrative work in between. So it gets the data from the satellite, the HRSN provider, it gets the information on claims, it converts it into the information that needs to go to the plan and sends it on up. And so really the HRSN provider can focus on the work that they're doing on the ground. They don't need to get all into the nitty-gritty of some of the things we've been talking about coding and different things in that big payment chart. And rather that parent entity deals with all of that administrative work, and it can reduce the amount of contracts that the parties have to have. So you could have a contract with the parent entity, and the parent entity could have, 10 contracts with satellite entities, and then the parent could have 3, 5, 6 contracts with our health plan. So a way to reduce some of this administrative burden. Big takeaway here is entities that could be a parent entity or a satellite entity are social service organizations, so our HRSN providers. It could be an ACO partner, it could be an ACPP, could be a PCACO, it could be an MBHP. So lots of folks could be a parent or a satellite. You do need to get a new MPI number you need to be credentialed, you need to go ahead and be registered with MassHealth as a MCE only provider. We talk about that also a little bit in some of these other webinars, but essentially that means, again, you need to get your MPI number. One exception, if you are an HRSN provider and you are also the parent entity, you only need one MPI number. I know that's quick, but that's the big takeaway here, that lots of folks could be a parent and satellite, and we want to really make sure that you go ahead and get that MPI number as a first step, and then second step, we'll talk credentialing. All right, so we're going to move into the HRSN budget, and we're going to follow this, the next steps, and then I promise we'll be pretty much at questions. All right, so when we talk about budgets, I really want to focus on the bottom half of the slide here and help us understand the different pieces that make up how we get to a price, a budget, a service amount. There's actually some nuance here. So first, we have how much money do we have for the HRSN services, not specialized CSP, that's in a different world, that's normal required service, but how much for the rest of these supplemental services. And we estimate that we have between 35 and 45 million. That's our bucket of funding that we can spend collectively for HRSN services. This is an estimate right now because the state budget is not yet finalized. Hopefully we'll know that soon. All right, so that's point one. Point two is, what does MassHealth actually pay our ACOs and MBHP to provide these services? And this is called a capitation rate, an add-on capitation rate. So this is the amount that the ACOs are actually getting that will then convert to what the providers are getting. So this amount will be known in early October in an information sharing, and this is consistent with when rates are released yearly for covered services. And just for some background of why this is, there is a long process in which MassHealth works with its actuary to determine an appropriate rate. That rate must then be certified by CMS. We are working in record time to make sure all of this happens, but that's where this timing comes from. So this is a little bit of our missing piece right now. And then we have the service pricing, and that's what you've seen in these payment charts thus far. This is the amount that we are either giving as a directed amount in housing or a maximum amount in housing, or in nutrition, we're giving as a reference guide. And this is the amount that will actually be paid to the HRSN provider. So right now we have a pretty good idea of the first and third one, and we will be able to share more in the fall about the second one. We strongly recommend that plans and providers take the information they have today and start moving towards contracting, working towards credentialing with the information that you have. You do not wait. We'll look at the timeline really quickly, and we'll see that we really need to move forward. We can't just wait. All right, so next slide for our timeline. Made it. All right, where are we? So we are here on July 18th. We are having this public meeting. We've released the HRSN Service Manual. And after today, we're looking to August. We're looking to release ACO requirements and readiness review. And so what that will look like is a draft contract for the ACOs. This is particularly for HRSN services. So just that section, heavily caveated is that it will be a draft. It will need to be approved by CMS, but we want to get that to you as soon as we can. That will have things more like details on what you need to do for wait lists, information on service plans. It will codify things that we've talked about a little bit here that you might not see in a service manual, like you must provide a housing service and a nutrition service. That is more meant to be in a contract, but we have tried to preview some of those really baseline fundamental pieces of information with you here. Additionally, at that point, we will kick off readiness review. For those not familiar with readiness review, this is a period of time where we will ask the ACOs to collect and then submit information that tells us they are either ready for launch or a plan to get ready for launch. Likely, it will be the latter in this case, because we generally anticipate that in mid-September, there will be a submission of readiness review. This is connected to CMS requirements and dates for which we are looking for an extension. So we realize a lot of this is very quick. We hope to have that, but recognizing now and sharing now that there may be a very quick time period turnaround in which we have readiness review released in August and due in mid-September. We are very aware of this. We will make sure that we have a manageable readiness review. In September, we also then expect in this that you'll be selecting your services and really beginning or continuing to contract with providers. In October, you'll get that add-on payment information, and then we will march forward through to January 1. We will no longer have flexible services. It will have been sunset December 31st. On January 1, we have HRSN implementation and the beginning of HRSN services. Okay, so we wanted to leave about 30 minutes. We made it for question and answers. We have been working in rapid speed behind the scenes as you have been asking questions to prepare to answer your questions. At this point, we ask that you no longer put questions in the chat. We will start to answer the many questions that you have provided, wonderful questions. My colleague Eliza Norcross will do that. And then if we get to a point where we have run out of questions,